I think the best way to think of the Affordable Care Act is really more of insurance reform as opposed to healthcare provider reform. Today, a lot of the decisions are made by your employer and what insurance plans you have, by your insurance companies, and then lastly by healthcare, and then finally to the end by the patient who doesn't necessarily understand what plan they're in. So that is exactly, I think, the goal is to provide a greater transparency to the consumer of care, the patient themselves. The question is, who bears the cost? I think post-World War II, we saw a lot of costs going to the employers. It just happened that way. And so in the United States today, it's almost a given right of employment that you'll see that you're compensated with insurance. I think that needs to change quite a bit, because then when you get an increase in unemployment, you get a lot of uninsured individuals. So this combination between providing state or governmental insurance and commercial insurance is where some of the challenge is. And I think also the role of insurance companies themselves is some of the challenge. The more intermediaries you put in the care process, the more you're going to increase costs. I think also the less transparent costs are, the more opportunity there is for escalation in price. So the right way to do this, if you can get to the other side, is to be very transparent, not just to the care that you're going to get, the quality as a consumer, but to the exact cost that you're paying for that. I think there's a couple of areas where innovation may increase and innovation may decrease, and I think it will follow the dollars. But I think in the larger picture, what we're seeing is an increase in technology in healthcare. So whereas before there was not necessarily a strong push or incentive to have people put in electronic medical records, there was no penetration of electronic medical records. 10 years ago, it was less than 10% penetration in the United States. And you can imagine the bureaucratic slowness of moving paper around while taking care of patients, as well as the inefficiency and quality in care when you don't have access to people's previous records. So what's happened is a rapid deployment of electronic health record technology throughout the United States. That acts as a foundation for other technologies that can go on top of that. The primary care providers, and they might not be physicians, they might be paraprofessionals today that rise up and provide greater care, will have a stronger ability to provide more direct care, maybe with more information. So it might take less years for an individual to train for providing care because they might have more technological knowledge at their fingertips when they're making decisions. So that's one piece of it. So you can imagine, IBM's project of Watson, which allows the ability to mine an entire patient's record and say, here's what I think you should do. You could make the workers a lot smarter. So I think that's going to happen because big data will be able to be mined. And I think that when you look into other areas, such as you mentioned oncology, or again back to medical imaging, where it's a tough decision for a physician who doesn't practice all the time in that area to say, what do I do next? How do I treat the patient? You can imagine decision support guidelines that could step you through the process of making those advanced decisions, so long as all of that patient's data is available in an electronic format.